Good day, everybody. We start in about 15 minutes. Hello, Danu. Anybody want to say hi? Yeah, that's okay. I'm one of those obnoxious guys at a conference that comes up to you before it starts. Hi. And you want to concentrate, you want to do some other things, you want to meet your friend.
Hello, John.
Is that Dan? Who's that?
That's Firas.
Hey, how you doing?
Fine, very well. Thank you.
Very good. Welcome here.
Thank you.
I can't. I guess you're not on camera, huh?
Yeah, it is off.
Oh, is that you, Danu, or who am I talking to? Gabriel? Is that Gabriel? Danu, I see you. Danu, where are you at? Are you at home? Unmute, Danu. Unmute. Unmute.
Yeah, I'm at home right now.
Oh, okay.
Yeah.
Hey, you know.
Good to see you, John.
Yeah, Juha's girlfriend's from Indonesia. You know that, right?
Yes. I got friends. I got friends.
Yeah, Fitri. I don't know if you know her.
There's Baseri Fitri. I think yes.
She's a anesthesiologist.
Is he now? Is he here now with us?
Juha's not here yet. He'll be here in a couple of minutes.
Amazing. It'll be fun.
You met Juha, right?
Excuse me?
I know you asked some questions. Have you met him? Have you met Juha?
Yeah. I met Professor Juha when he came to our hospital when I was having residency program about 5 years ago.
Oh wow,
in
that
Jakarta.
long.
Yeah, it was.
Was that a big deal at the hospital?
Yeah.
Oh my God.
The hospital was the most advanced hospital in Indonesia, where I studied neurosurgery.
Really?
Back then. Yeah.
Hello.
he performed the echo aneurysm with the lateral supraorbital approach. He published and he invented.
Oh, that's
It
great.
was amazing.
Well, that's great. Okay, Danu, welcome. Hello, Ada. Are you there?
Thank you.
Okay.
Hi,
Okay.
Dr. Bennett.
How you doing? Hello, Ada.
Good, thank you. Sorry, I'm on the ward. I just literally came to because of the caliber of the speakers. But yeah.
Okay,
I was just
listen,
here.
Ada. Listen, Ada. You want to go to China, right? And you want
Yes.
to train. You want to train with Juha for a couple of months, right?
I would love to.
Okay. Okay. Let me tell him right now. Okay, he's here. Let me tell him. Hold on. Ada, you got your photo? You got your camera working or no?
Yeah, I'm trying to turn it on. It's telling me that I have to modify my Zoom settings. Like always keep it off for our meetings, but let me 1 second.
Okay, if you can, we'll give.
Yeah, that'd be great. Yeah.
Yeah, because Juha's here. I want to introduce you to him and tell him you want to go to China.
I would love to.
He needs a digital person there. You know what I mean?
Yeah, absolutely.
He
I
really
know.
needs a digital person. I think he would welcome you because
Thank
I know
you,
you're
Dr.
I know you're very good at computers, right? I know
Right.
that. Hey, Juha.
Hello, John. Hello, John.
Nice to see you.
Nice
Hi,
to see you.
Professor.
Hey, listen,
Hello,
Juha.
John.
I want. Hey,
Hi.
Ben. How you
Hi, John.
doing? Nice to see
Fine.
you.
Nice to see you.
Juha, I want you to meet Ada. She's a
Hi.
really good digital person. She's a medical student. She wants to come to China for a month or two.
We met last year at Bypass course in Zurich in January. The one organized by Professor
Professor
Rainey.
Subin you met.
Yes.
Yeah.
Subin
Yeah.
was there.
Yeah.
I have not been there.
Dolenc, yes.
Okay, should she write to you, Juha? She'll just write to you to arrange it, or?
Yes, we can arrange, but now because of the pandemic,
Yeah.
so it's all closed.
Okay.
Yeah.
When we reopen, we can arrange her visiting.
Thank you.
Okay, very good. Very
Thank you
good.
so much.
Yeah.
Okay.
You can write an email to me and.
I will. I have still your card in my purse. You gave me your card at the dinner, so I have it.
Okay.
Thank you.
You're welcome.
She's giving a talk on Sunday on robotic, on virtual reality and
She's from
neurosurgery.
London?
Neurosurgery.
London?
Yeah, it's going to be on neurosurgical TV
Okay, so the
on Sunday. Yeah, I'll send
Yeah.
you the banner and everything Sunday about the same time. Dr. Sano's here.
And Vinko?
Not yet.
Hello. Hello.
Hello, Professor
Hello,
Sano.
Professor Sano.
Hi.
Hello, Professor Hirotoshi Sano.
Hello.
Hello.
Welcome, Dr. Sano.
Yes. Now I'm
You should-
putting the.
Yeah, you're setting your camera up, right?
Yeah, I am putting on the.
So Ben, you're going to operate the video, the PowerPoint of Vinko?
Yes, Dr. Liao will.
Oh,
He
he's
will
here now.
translate it.
He's
Yeah,
here. He's
yeah.
here now.
Yeah.
Okay, so he's going to be doing that.
Mhm.
Okay, we got 9 minutes.
We have 9 more minutes.
Yeah.
Mhm.
Does anybody else have questions or comments they want to say? Well, you know, Ada, this will be like a conference where people kind of meet each other before and meet each other after. Eventually, when people get real comfortable with it.
Yes, I know how you run these seminars, and it's very interactive. I've followed a few in the past.
Yeah, you know, when people get comfortable with it, because I think people are kind of learning how to operate the mute button and learning Zoom a little bit. But here's Vinko.
Yes, Vinko.
Yeah, he's here. He's here. That's great. That's great. Ada, you know Vinko, right? You met him?
Okay. It's
Vinko?
muted.
Hello, Vinko.
He's
Can you
setting
hear
up.
me?
He's setting up. He's here.
Uh,
The man is here. There he is. You can tell Vinko's here because he takes over the screen. Hello, Vinko.
It's muted.
Yeah, Vinko, are you there? I think his associates are. Juha, he's not presenting. Is he showing something?
Yeah,
or-
I will make a short introduction. I will
Okay.
make a very short introduction because he's
Okay.
so well known.
Okay, I'll just introduce you and you just run. Borlath is coming. Let me check with her. She should be here.
What is that? This is Vinko's screen? Yeah. Yes. Vinko Dolenc.
Hello, Vinko, are you there? He must be, I think his associate's just setting it up for him.
Mhm. Ah, okay. He's sharing the screen now.
Does Dr. Ben? Oh, okay.
Yes.
Does Dr. Liao have two connections or he seems to be coming in and out? Does he have a good connection? I think. Okay. Okay, Vinko, is that you screen sharing? Because I gotta bump you off for the introductions. Okay, there we go. Good, we got 3 minutes. Dr. Liao keeps falling off.
Yeah,
Yes,
Dr.
I'm
Liao,
here. John,
yeah.
I'm here. I'm Dr. Liao.
Hey, Vinko, is that you?
No. This is Dr. Liao.
Oh, okay, Dr. Yao.
Yeah,
Yeah,
yeah.
you keep falling off. Are you okay?
Yeah, I'm okay.
Okay.
Nice to meet you. Nice to see
Yeah,
you.
nice to see you again. You know,
Yeah.
so you're gonna do the translating tonight?
Yes.
Yes.
Okay. So I'll introduce you, right? You got a camera?
Yes.
You got a camera, Dr. Yao, right? Because I'm gonna introduce you.
小廖，你打开视频。
我打开了，徐老师。
好。
Yeah, we appreciate you translating. It's you. But Dr. Liao, you are a neurosurgeon too, right?
Yes.
Yeah.
Yes.
Do people remark that the translation is really good because he's a neurosurgeon? Do they say that then or no? Oh, well.
Yes, he is my colleague and assistant.
Oh, okay.
You know, he work in the same team as me.
Well, you know, but the people are getting a good translation. Right? Someone that speaks it fluently and translates with neurosurgical knowledge.
Yes, he is a neurosurgeon.
Yeah, that's great.
Mm-hmm.
Okay, 1 minute. Okay, I got to bump you off the screen share, Vinko, or whoever is screen sharing. Oh. Okay, Vinko, I'm going to bump you off, or whoever is screen sharing. To start. Okay. Okay, you guys ready? Okay, 10, 9, 8, 7, 6, 5. Oh, let me remove the spotlight. Oh, hold on. Okay, 10, 9, 8. Let me get something. Hold on, let me just straighten out something. For some reason, it's. Oh, Vinko, hello, Vinko.
Wait.
Okay. I gotta get him off the screen share. I gotta bump you off there, Vinko. I'm just gonna bump you off for just an introduction. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett of Neurosurgical TV. We have the pleasure of having Juha's China Neurosurgery Grand Rounds with a variety of topics, and I'm going to turn it over to Warlix. Warlix, you there? Hello, Warlix. She's a little slow in the butt. Well, I'll just turn it over to Juha. Okay, Juha, welcome, and it's all yours.
Yeah. Okay, dear colleagues. Today we have one of the greatest neurosurgeons of all the times presenting his story. Vinko Dolenc. When you say Vinko Dolenc, wherever in the world, then everyone knows him. So only few neurosurgeons could change the world, and Vinko Dolenc is certainly one of them. So as it follows, you will hear that the route to governor science was not easy. Vinko Dolenc is coming from an extremely small country in the middle of Europe, Slovenia, with 2 million people. And this is extremely small country, even in Europe. In China, it would be a small village. So Slovenia was formerly a part of Yugoslavia. And
Okay, I'll get that. I'm sorry.
okay. Did you hear me?
Yes.
Okay. And one of the other difficulties, besides the extremely small country, was that he was studying and growing up behind the Iron Court. I don't know if all the world knows what was Iron Court. Iron Court was dividing Europe in two parts, eastern and western part. And in the eastern part, it was extremely strict conditions, so very, very difficult to manage and to have international connections. So Slovenia became independent in 91. Ljubljana is its capital, and there Vinko has done main part of the work in his own country, but he has been operating all around the world, in USA, around the world in many countries, also in China by us in Southern Congress. So Vinko Dolenc has done more than 3,000 cavernous sinus operations, and as we see here in the world neurosurgery, 59 most important neurosurgeons in the last 100 years. And here is the little bit younger, handsome Vinko Dolenc. So I will give the word to Vinko Dolenc. He will tell his story, and this very interesting story. So please take care and join us. Vinko, the word is yours.
Okay, Vinko, you there, right? Now it's time to screen share. He doesn't want to screen. Hello, Vinko.
Please unmute.
Okay, let me unmute him. Great. We'll get it. We'll get it. This thing in there.
He's mute. Vinko, you are mute. We don't hear you, Vinko. You should.
I'm checking on this end here. Oh, there he is. Okay, let me see if I can unmute him here. Yeah, he's going to unmute himself. Hello, Vinko, you need to unmute.
Click the left button.
Okay. Oop, I think he fell off. Just be patient. Be patient. He doesn't have any large files that he's sharing, right? He's just. Okay, he'll be back. So we take a digital coffee break. We'll just wait. He'll be back.
First one.
So any change in the COVID situation in China?
Actually not. There were 15 cases yesterday.
In one day, wow, on the whole country.
Whole China, yeah.
Wow.
Only 2 domestic cases.
What's
The
the
others
street?
are imported cases.
Oh, okay.
Mhm.
Are you restricted in the city in Shanghai from moving around or? Oh, here, okay, Vinko's here.
Okay.
Okay, start sharing, but now we gotta get the audio. Hello, Vinko. He may be sharing, but doesn't know. Technology. Oh boy. He had an associate with him last time. He must be alone. You don't have his phone, do you?
I don't have his cellular. No, I
Oh,
just sent
okay.
him email.
Okay, okay, good, good. He responds to email. Okay, he fell off again. He'll be coming back. Just be patient, everybody. Sorry, everybody. We should be starting in a few minutes. I'm sure we'll get this sorted out. Just keep my fingers crossed. He's not back in yet.
Is no more here? Vinko?
Not yet. Not yet.
He might encounter some difficulties.
Yeah, because it's fine.
I wonder if he had some kind of problem there because he's not coming back.
John, I think another solution is we can play his PowerPoint, and then he just need to speak.
Okay, we can do that.
Yeah, so
You wanna-
maybe
okay.
his
It's not more connected.
And yeah, in the meanwhile, we'll wait. We'll watch his connection.
yeah.
Can you go ahead and present that that PowerPoint, Ben?
This is not good, but let's wait 5 minutes.
Okay, okay.
He has certainly some difficulties, so I hope somebody is coming to help him.
Yeah, the last time we had an associate there, we had that was kind of running everything. Hello, Danu. How are things in Indonesia with the COVID?
Yes, COVID in Indonesia is going pretty horrendously.
Right.
We get 6,000 cases per day,
Per day?
approximately.
Well,
Yeah.
is there, are the restrictions on moving around?
Yeah. We restrict everyone from moving around cities to the other cities and areas to another areas. We're still struggling because, I think everybody is trying so hard to do the health protocols with mask wearing and hand washing, but still going very uncontrollable.
Oh, okay. Okay, still no bingo. Okay, he's back. Let's give this a shot. Okay, folks, let's try to get connected here.
Oh.
Okay. Now the camera's working.
But unmute.
Yeah, I cannot, he's gotta unmute himself there.
Can you hear me, Vinko?
Okay, he's screen sharing. one step at a time. We got the video. Now we're just gonna get the audio.
Nico, it's I think it's on the upside of left.
Okay, I'm texting him. Okay. I think he's looking for the mute button on his PowerPoint. Yeah. Okay, we sent him an email, we've texted him. But I think he's lost there on the looking for the mute button on the PowerPoint. Hello, Vinko, can you hear?
ছোটখাটো শ্যামলা ছোটখাটো
Yeah. Not trying to remote control.
Okay. I can do it.
John,
Yes, oh, yes, Warlicks.
you can do the request for his remote control. So I just try it. You can request for a remote control and you can control for himself. I try.
Yeah, go ahead, let's try it. Let's try it. Let's try anything. Hey, let me make you, hold on.
Try to unmute him.
You are host. Can't you unmute him?
Yeah, I'm making you co-host there, Alex, too. Yeah, I've been trying to unmute him from the control panel, but without his cooperation, I can't do much.
Okay, let's see. Ask to unmute.
Yeah, I've asked to unmute. You have that control, right?
Okay,
Too.
he not,
Oh wait, he's on. Wait, his voice. Vinko, you're there.
Okay.
I think he's
We
there.
are connected.
Hey, right, all right. Thank you for your help.
Hey, good. Thank you very much. Thank you. Okay, you can go to the rest.
No, I also want to.
What?
You can ask for okay. Seem okay now.
Jaz se pravim, Dolenc vprašaj jih, če ja, tebe, ja, to.
Do you see my slide?
Yes, we do. Welcome,
John.
Vinko. Welcome. Thank you.
Okay.
Thank you.
Go
Yes.
to beginning. Go to beginning. Okay.
Ja,
So I started. Yeah. So we had to introduce microsurgical techniques first. Microsurgery was not available at that time. So I could start on peripheral nerves and then slowly on small vessels. And then I could go into the intracranial pathologies. But along this, I was studying the cavernous sinus anatomy. Then I promoted it, and later on, I had to protect it. Now it doesn't work again. It's incredible. Yeah. No, then now I cannot go further. Requesting remote.
Yeah, at the bottom left, Vinko, there's an arrow at the bottom left. There you go. That area, you see the arrow at the bottom left?
The bottom left, yeah, okay.
Okay.
So there is a special microscope story in all this story. An air crash happened in 1966 in Ljubljana. Many people were killed. 18 of them survived, and they were brought to the general surgery department. The British were very satisfied with the handling, with the how we treated them, and then the ambassador, Mr. Archie Mackenzie, came later on to Ljubljana to offer some help to the hospital. And this was different equipment and so on. And my professor, Juha, who spent some time in France with the first professor of neurosurgery, Clovis Vincent, in 1939, said, I don't need usual things. What I need is operative microscope. But since this operative microscope is not in England, please buy it for me in Germany. Mackenzie said, no, it is not possible, because everything what is existing in the world is existing also in UK. So finally, they made a deal, and Mackenzie said, I will find out if they have a microscope or not in Britain. If they have it, you will get it, and if you will not, if I will not find it, we will buy it one at Opton. So it was very, very positive for neurosurgery because Professor Zoomer was chief of general surgery, but he was very much into neurosurgery. So the war, so-called, for neurosurgical department, which is now very difficult to understand, started. And then also for neuroradiology, for neuroanesthesia, and even more important for neurosurgical specialization. And this is the microscope, which came from Britain late in 68. And we were using it. I operated almost 400 peripheral nerves patients on this microscope. And we started also using it for vascular pathologies. At that time, the first publication on microsurgical treatment of injured peripheral nerves came from Dr. Dr. Smith in 1967 from Walter Reed Hospital in the United States. And this was a great help for and stimulus for us to start with peripheral nerve surgery. A friend of mine from the primary school came out from general surgery consultation and was very sad. I said, what happened? He said, they told me my radial nerve is completely out. They cannot help. And I sent him back to the surgeon, to the general surgeon. Please ask him to put it in writing. So he went in, the surgeon was angry, but anyhow, he wrote, we cannot help this patient because only transfer tendons might be surgery. So later on, I operated this illegally with special team in the hospital. 6 months later, he came to the same surgeon and he showed him how he can extend the wrist. So I had the first person in this hospital who was helping me. And so we started, and more and more peripheral nerves were treated. The first microneurosurgical meeting was in Vienna in 1970. Contraves microscope was presented by Yashergil, and also we presented some peripheral nerves results. And it was going on, and I had to operate many peripheral nerves. So we installed a microanatomy laboratory in 1974. Again, there was fight for microinstruments, there was fight for space, there was fight for drills, and we had only formalin fixed specimens, which were not good. But the number of peripheral nerve injury patients was growing exponentially. And I realized that the colleagues, good colleagues, first, they don't allow you to work, they don't give you, but when you succeed, they give you too much. So they can block you on the other way. What to do? I realized that I have to spread the knowledge. I have to teach other people. And then I will have less of those patients. And among these courses, Yashergil was with us at 1978. You can see him here. And Diane. He was lecturing about the small vessel repair, about the microsurgery, and so on. And this was great help. We started with intracranial microvascular surgery. And at that time, it was not very widely spread, the use of microscope. And since I was able to use the microscope and we got a new one, I was able to start with aneurysm surgery in acute stage, because at that time it was an algorithm that an aneurysm patient has to be 6 weeks in the bed and only then he can be operated. But many patients died in between. So I said, why to wait? Let's give them the chance. And so the vascular surgery, aneurysm surgery was developing, was growing in our department. And also other surgeons were doing it. And then at 78, I was asked by an elderly colleague to help him in a carotid ophthalmic aneurysm, which was incidental. The patient was normal, but this aneurysm was shown and they decided to operate. And I was assistant at this surgery. Intraoperative rupture clipping was not possible. We ended up with packing of aneurysm and ICA, and the patient died. And this was a great, great shock for me. I didn't know what to say, what to think. And next day, when we were considering the aspects, the decisions, the actions, and explanations what was done wrongly and what should be done differently. And there were thousands of ifs. And I was under heavy pressure, and I said to myself, if there is no other way, I have to go out of neurosurgery. I have to go somewhere else. And then the second eye told me, don't accept the defeat too early. Do not accept to be the carrier of the genome only. To surrender to what? To the norms, to the lack of knowledge, to the family which wanted me to be with them more time, or to surrender to oneself, to myself, and this is what hurts too much and forever. So the answer was no surrender. I was thinking that blind believing is easier than to check and find the correct answer. And it came to my mind that the idea without action is like a dream, that the action without idea is like to get out of the step, and that the idea with correct action is a positive difference between them. Different approach in thinking and in acting. Forget the previous beliefs regarding the no man's land and prove that there is no man's land. The answer was nothing is impossible. Because I came back and again to this patient where we did not have a space around the aneurysm and we were not able to do the right action. How this can be achieved? New ideas. And then I said to myself, don't be arrogant. You have to read. There must be some publications. Read, read, and read. New era, new microscope, microanatomy, cavernous studies on injected fresh cadaver specimens. We needed a lot of time to realize that formalin fixed specimens are not good. They are not showing the right relations between different structures. So before we came to this idea that fresh specimens with injections, they are the best for the study. And then we realized the most what can be achieved in the anatomy is to understand it. And the most what can be achieved in surgery is to make the practical use of the anatomy. If you go to the skull base, you realize there is skeleton, there are membranes, there is ICA, there are cranial nerves, there are triangular windows into the cavernous sinus, and there are venous compartments. You have to study all of them, separate and together. This is the right skull base ICA as it is when the head is positioned in normal position. And it goes from the posterior lower corner of the cube to the anterior upper corner. So it is heading. And it is also looping. We have a lateral loop, we have a posterior loop, we have a medial loop, and we have an anterior loop. And of course, the blood inside these segments of the artery is spinning. So the normal question is, why is this so? And not so many medical studies were made, but the veterinarians, they studied that this is most probably as a heat exchanger in the animals. And Rabbi Chong from France, he said that the pulsation of the artery does act as a pump of venous blood. This is how the illustrator does see it. And you can see the sixth nerve, which is the only one in the cavernous sinus space, intracavernous artery, proximal ring and distal ring, and here is the anterior clinoid. Note that the intracavernous horizontal portion of the artery and intradural are parallel, are very close together. Again, the study of the anatomy at the lab, the relation between the artery and the nerves and the bone. And this is a fresh specimen injected. The artery is injected, the venous system is injected, and we can study, we can enjoy optic nerve, ophthalmic artery, neural ring, proximal ring, the nerves, and so on. When we study closer, we see that proximal ring, which is a membrane around the carotid, is the limit of the cavernous sinus and the extracavernous sinus. Then we can see the triangular spaces or windows, or you name them as you like, but you will see that this is so-called anteromedial triangle, where is optic nerve, the third nerve, and the tentorial edge. And then Parkinson triangle. The interesting is that this triangle is existing only very posteriorly. To enlarge it, you have to dissect the fourth nerve away from the V1. And then there is anterior, lateral, and posterior. In the posterior triangle, you can expose the petrous artery, ICA. When you go into the posterior fossa and you open the cavernous sinus from behind, from the posterior fossa, you can trace the sixth nerve, which is entering the cavernous sinus through the Dolenc space, and then it is climbing over the carotid, and this is the venous blood around. So I had quite an amount of anatomical knowledge and experience in the sections of cadavers, and also in some clinical cases. And then I presented this at the international meeting in Munich in 1981, the anatomy of the cavernous sinus. And I was considered to be insane. Nobody was in agreement. Only two people, Professor House from LA and another one. So they were criticizing me. They said, oh, this man is crazy. We'll just kick him out. And I was again under the question to give up, or then the second eye said to me, better to convince neurosurgeons that this is something. I had the impression that I was walking through the jungle, through rainforest, and I was trying to make a chart for no man's land, for which the majority did not agree. But interestingly, when I turned back, I saw that there was already a highway behind me. I was so happy that people were following, that people were trying to do it. And then I tried to publish. My first publication was able to be done in '83. It was incredible resistance. Again, I wanted to give up. Again, I said, if I cannot publish, I cannot spread the knowledge. Finally, with help of some colleagues, I was able to publish. And this is in the Journal of Neurosurgery, number 58. And then the second publication in '85, in the number of 62, it was much easier. And there I published the combined epi and subdural direct approach to the carotid ophthalmic artery aneurysms. Less resistance, and I consider this like green light. But somehow I was not satisfied with this. I said, this is not enough. We have to organize a symposium for the cavernous sinus, and we did in 1986. So the cavernous sinus was born somehow, was charted. And it was incredible. When I wrote to Professor Taptas, who did a lot of studies on the anatomy on the cadavers during the Second World War in Paris, because he could not leave Paris and go back to Greece. And he spent more than 2 years in the lab. And he studied the skull base, the central skull base. When he wrote my invitation, when he read my invitation, he wrote me a letter. Now I can die because you are the person who is interesting for this interesting area. And he was so happy to come. And also Professor Parkinson, who did some surgeries in the area, in the region of the cavernous sinus with the blood standstill. And also the others, also Dolenc and Dr. Sant. So we had different and very, very sinus was somehow born. And for this meeting, we published this book. Now, we had another problem, how to protect the cavernous sinus. Too many people were jumping in without previous study of the anatomy. And then, because radiosurgery was existing already, they said, no, 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 surgeons are making too much disasters. We can do this with radiosurgery. Endovascular interventional people, they came, they said, oh, we can do what you cannot. Endoscopic treatment, they said we can come from the splanchno-cranium. And there were also people who wanted to wait and see what will happen, because these pathologies are advancing slowly. So radiosurgery was the whole army of new gamma knife people came, and they said, no, 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 this is our territory, we can do it. Endovascular surgery, they said we can reach every and any vessel in the brain and also in the cavernous sinus. And endoscopic surgery, they can do everything through the little hole. Of course, I did not agree. What to do? Demonstrate what is possible and what is needed. Because my conviction was that the eyes do not see what the brain does not know. Yashar Gil told me, you know, I was already operating in the cavernous sinus, but I did not know where I were, because tumor pulled me into the region, but I didn't know what the structures are. And to study fresh, injected specimens, you can enjoy, you can understand the whole complexity of it. I realized that a manual book to demonstrate microdissections in the laboratory and surgeries in the cavernous sinus pathologies is needed. So we were able to put this together, and this was presented first time in International Neurosurgical Meeting in New Delhi in 1989. But what happened? More questions, more visitors, more attacks at the international meetings, and I was not able to explain everything in a few minutes, because this is the whole new territory. I operated a patient who wrote me this sentence: not everyone who does hit you with the knife is your enemy. So he was satisfied with my surgery. And then I added, and not everyone who does treat you without the knife is your friend. What means endoscopic, endovascular, radiosurgery, they have their value, but they cannot substitute completely the microsurgical techniques. So to promote, I participated and organized international workshops. I was faculty and organizer in many countries. This is, for instance, one from the Shuttlesville, Virginia, in '91. I went several years also to St. Louis, and also there. And what happened? The first Federation of Neurosurgical surgery offered to me the certificate that I am able to teach people. You know, now we came around, and it was funny. So I was teaching abroad in many neurosurgical departments, and I performed surgeries. I was also teaching at the Ether Dome in Boston. As you know, 1845, the ether anesthesia was performed here. They thought it was the first, but not one happened before already 2 years. I was invited as a speaker in many events and in for many topics. Invited to perform surgery in a lot of countries. The policy to share is a must. However, it is good to publish soon enough. Aneurysms in question, for which the knowledge of the cavernous sinus anatomy is beneficial, are carotid ophthalmic, intracavernous, basilar tip, and also large and giant intradural. And the pioneers of the approaches to the individual aneurysms are listed here. And Drake was at the cutting edge. That's why he was allowed to have to smoke a cigar under this sign. The principal problem of the approaches is working space around the aneurysm and between the vital structures. New approaches needed in thinking, in acting. Carotid ophthalmic aneurysm. You have to be in good command of the knowledge of the area, where the optic nerve is, where the ophthalmic artery is, where the dural ring is, and then how the extradural ICA from the cavernous sinus is entering the interdural space. And if you cut this dura, you get more space after removal of the anterior clinoid. You can put the clips. You can repair the carotid artery directly. I started with longitudinal incision of the dura along the Silvian fissure in order not to compress the brain. And you expose the intracavernous portion of the carotid interdural, and you can put the curved clip on the aneurysm. Even you don't need to visualize the optic nerve and the whole aneurysm. You just go around the neck. As I said, you can put the clips. You can resect the aneurysm and suture the carotid. And this is one before and after. And as I said, I use the longitudinal incision of the dura toward the artery, the carotid artery, and then I do the dissection of the Silvian fissure very centrally. I could present the aneurysm. I do not need to retract all the brain. I just need to visualize the carotid, the artery, and the neck of the aneurysm. But I don't see it yet here perfectly. That's why I remove the anterior clinoid. I remove the walls of the optic canal. You see, I'm under the aneurysm. This is the brain, this is the aneurysm. And here the aneurysm comes out. So I need more space. I have to cut the dura more toward the dural ring. And to see how the anterior loop of the carotid is running. So this is the optic nerve. We cut the dura more. We go down, down. And then I put a stitch here on this dura and I pull it up. So I lift the optic nerve away and expose the aneurysm more. I don't need to expose the whole aneurysm. I just need to see correctly the exit point of the aneurysm from the carotid. If necessary, as it was here, I can drill a little bit more optic strode. And then I can resect more. And now I can go along the artery, the dural, the anterior loop. So this is the intradural. Carotid is here. And this is the aneurysm. The optic nerve is there. And then the optic nerve is displaced. You see the optic nerve here? You see the optic nerve? You see it? And now I hold the aneurysm and then I can put the clip here. But I could not put this clip easily if I would not have this space. So with the left hand, I can come with a clip. I put the clip on the aneurysm neck. I visualize the optic nerve. I cut the aneurysm. I cut the aneurysm and empty it, and that's it. And then underneath I have the optic nerve. I just leave the sac of the aneurysm. I don't need to tear it away from the brain. The optic nerve. And this was really a delight. How useful is to know the carotid, the cavernous sinus. You see? Getting space, that's the most important. This is before, this is afterwards. You see carotophthalmic is here. You see also the ACE, anterior cerebral artery, second segment, and you see the clip. So this is the series, but which is not so important. They were small, they were large, they were giant. And the resection and reconstruction of the artery were used in this percentage. Cavernous sinus ICA aneurysms. Why to operate? We are under constant attack of endovascular people. But also they cannot be successful in all the cases. When the aneurysm is bilateral, if you occlude one artery on one side where the bigger aneurysm is, the other aneurysm will start growing. If you have a large fusiform aneurysm, or if you have a traumatic aneurysm, it is better to come directly into the field and to solve the problem. How to get rid of the anterior clinoid process safely? Get space around the ICA and dissect the ICA and the optic nerve free. Get the control of the blood flow in the ICA through the cavernous sinus segment of teeth. So you expose the anterior loop of the carotid artery. Optic nerve is here, the proximal ring is here, lateral wall of the cavernous sinus is there, and there is V2. And posteriorly, behind the V3 engaserion ganglion, you expose the ICA, the posterior loop. So when you have two points where you can interrupt the flow through the carotid, through the cavernous sinus, you can deal with the aneurysm. Here is such a case, resection of the aneurysm and reconstruction of the ICA from here to here. And the ophthalmic artery there. Another one, it was resected and reconstructed artery in this segment. Another one, pre and post, dealt only with the sutures. Another one, this one, bilateral. If you occlude this artery, this aneurysm will grow faster. If you remove this artery with surgical approach and you preserve the carotid, then you just follow this and it will not grow fast. This is left intracavernous ICA. We visualize the optic nerve. The anterior clinoid is removed. Now we go posteriorly where the middle meningeal artery is. We can visualize it better. We see the third nerve. Here is the middle meningeal artery already cut. And here is the carotid in the petrous bone. We make it free so that it will be possible to clip it later on. Where you drill 5 to 10 millimeters away from the middle, from the foramen spinosum. You dissect it from the bone. And then you get it ready for the clipping. Now we get ready also in the intradural space. We dissect the carotid. If necessary, we can put the clip here. Preferably, we put it in the cavernous sinus. This is the place where was anterior glanoid. This is the place where was the anterior glanoid from. And because the space, the cavernous space, was filled with the aneurysm, it is adherent, the lateral wall, to the dura on the temporal lobe. So you have to dissect it sharply. If we go further, we have here the carotid in the petrous bone. We have the third division. We have the second division. And we have here the oculomotor nerve. With the curved knife, we go along and we dissect the optic nerve, the oculomotor nerve. Or we make it free from both sides. Everything is in adhesion. The oculomotor nerve is this. We are proceeding now laterally to find the fourth nerve. And then we try to find the carotid in the cavernous sinus. That is distal from the aneurysm. And we can put the clip there. In nowadays, it is possible to use the tissue coil and to stop the bleeding. At that time, we were still using the surgical. The carotid is there. We try to put the clip. So the clip at the anterior loop, the clip in the petrous segment, and then we have the aneurysm. We have the fourth nerve here. We are enlarging the Parkinson's triangle. Sharply. More. We are now on the lateral side of the aneurysm, visualizing the V1 and 6. So we are laterally now. Now we will cut the aneurysm. We have the nerves free. This is the aneurysm. This is the fourth nerve. And the third is here. Now we will cut the aneurysm here. We will open it. The aneurysm is open, and we get oriented in the aneurysm how the proximal stump is getting in how the distal stump is getting out. Then we know how to put the clips. And then we remove, when we finish with the aneurysm, we remove the package in the Petrus canal, we remove the clips, and we revise the whole situation. The carotid is pulsating, the anterior loop of the carotid is here, in the cavernous sinus, then it is running this way. This is intradurally here. So we were able to put the clip on the carotid at the anterior loop so that we did not have a retrograde flow from the ophthalmic artery. This is the aneurysm fixed, the fourth nerve preserved, the V1 and the sixth nerve preserved. Situation after surgery. Hmm? Is tape? Huh? Sorry. Ja, ja. Hier. And this is another aneurysm, which is actually in the cavernous sinus and also intradurally. So this can not be, or most probably, difficult for the endovascular. We're able to reconstruct the artery. Absolute indications for the carotid cavernous ICA reconstruction is when the artery is transected or lacerated, when it is transpersed, or when it is diseased. And here we have how with the balloon or with the stent you can find the distal stent of the artery. In my mind, it is very difficult. We were able to get in, we were able to find the distal stump of the carotid, and then we put the short, high flow graft in the cavernous sinus, and the arterial tree is presented. Here we have another situation. A nail was in the cavernous sinus through the carotid artery. And at surgery, we did the same. We removed the bone over the carotid in the petrous bone, and we removed the anterior clinoid, and we visualized the lateral wall of the cavernous sinus, and this is the nail. This is the anterior loop of the carotid. This is the optic nerve. Again, this is before surgery. we expose the optic nerve, the optic canal. We remove the anterior clinoid. We have here the anterior loop of the carotid. Anterior clinoid is completely removed. The ICA loop. Then we go laterally to the middle meningeal artery and to the Petrous canal of the carotid artery. We open the canal, we dissect the carotid from the bone, that we will be able to put the clip or packing the canal and to compress the carotid. Then we dissect around the nail, which is through the cavernous sinus, and visualize the ICA and the third nerve and the optic nerve there. Again, we find the anterior loop of the ICA. And then we follow the carotid retrogradely. We put some protection for the third nerve. So we put the stitch into the proximal ring so we can pull it up. So we have a ICA anterior loop. This is still in. Now we can dissect further. We can dissect further. We can put a clip here. We put a clip in the Petrous. You see ICA now here. We don't need to put a clip intradurally. It is better if you put it extradurally in the cavernous sinus at the anterior loop. So later on, we bring out the nail, we reconstruct the artery. When it is finished, then we open again the artery in the canal. We remove the clips, we remove the surgicel, we put in. We have the clip here still. So we have a cavernous sinus wall, we have a ICA anterior loop, optic nerve is there, anterior loop is here. And then we remove the clip. We put surgicel, or finally we put the fibrin glue. This surgery was done only extradurally. This is the nail. How can endovascular treatment be successful? But you can repair the carotid artery where it was injured. Then you need surgery also when you have a big aneurysms, because the living part of the aneurysm in the cavernous sinus is much smaller than the thrombotic part. And you see the very tiny carotid in the cavernous sinus. And in such cases, the artery is diseased proximally and distally to the aneurysm. So you remove the clot, you remove the aneurysm, you remove the diseased part of the carotid, and you put short, high flow graft. This is the statistic in small, large, giant, and overall PC, ICA results. Excellent diplopia, hemiparesis, and 3 patients died. Indication for surgery of basilar tip aneurysm, large and giant, complex, failed multiple coiling or stenting. Endovascular people, they say, no, we can treat all of them because this is very easy. You come with the catheter straight up and then you put the coils or whatever. But I think it's not so. It's not so, because look at this case. The patient came to me and he said, "Sir, my pocket is empty. Can you fix my aneurysm?" I had still the aneurysm. I had 3 bleeding, and how further? I said, okay, we can operate, and we opened it. We found the aneurysm. We found the coils. We were able to find the perforators and then remove the aneurysm and coils, and the patient was okay. But we do think that prior to operate on basilar tip aneurysm, one should be familiar with aneurysm surgery along the corridor. MCA, distal ICA, and carotidectomy. How to enlarge the intradural space, opening of the Sylvian fissure, shifting the wall of the cavernous sinus laterally. And of course, most of my knowledge I've stolen from previous teachers, Drake, Duke Sampson, Yashergill, and others. But also I used my brain, and I said, if I go here in the slit between the optic nerve and carotid artery, and if I try to come to the aneurysm there, I will stretch the perforators, and this is unforgivable. So it is much easier to come from the lateral side of the ICA and then to push the carotid medially. Then you will relax the perforators. In this way, you get space on the lateral side. You have under view the 3rd nerve, but on your way is the posterior clanoid process, which has to be removed because you have only this very little space. So you push the carotid medially, you visualize the posterior clanoid process, and then when you come down to the posterior fossa, through the anterior clanoid, posterior clanoid, and you are in the fossa, you go between the intradural segment of the carotid and intracavernous segment. This patient was pretty tricky. And with these maneuvers, we were able to exclude the aneurysm and preserve the perforators. They are crucial. They are vital. They do not tolerate clipping them, or they do not tolerate spasm on them. How this is possible? from Peter Bentivoglio from Australia, who was working also in Queen Square Hospital in London. And he did the experiments on the apes. And he was trying to find out for how long the animals survive and tolerate the clipping of the basilar artery. He found out that 3 minutes of clipping is not harmful. Then you have to relax. You have to remove the clip from the basilar artery for 5 minutes, and then you come back with the clips on the basilar, and you have 3 minutes time to dissect about and around the basilar artery, basilar and aneurysm. And then you can get orientation where the perforators are. How to get ready? Again, you have to know the anatomy of the anterior clinoid, of the carotid ophthalmic, of the transition of the carotid from the cavernous sinus to the intradural, and then you come extradurally. You visualize the optic nerve, visualize the anterior carotid artery, anterior loop, and you see the lateral wall of the cavernous sinus. It is also very useful if you train a little bit dexterity and other motor skills in the depth. And I was for 30 years with the constant hard talks with plastic surgeons. They kept saying, we don't need long instruments. But I said, we do need long instruments because we have to work in the depth. Very useful if you train yourself of the glass and if you try to put a stitch, because correct three-dimensional actions in the depths are crucial when you need to repair. In the lab, you can profit the knowledge. After removal of the anterior clinoid, visualizing the intradural segment of the carotid, the intracavernous segment of the carotid, the pituitary body. You are in the cella. You see, to the basilar artery, on your way is the posterior clinoid process. You remove the posterior clinoid process, and you have a very nice view of the distal segment of the basilar artery. And then you can deal with these aneurysms. I cannot go to the whole anatomical variations, high and low bifurcation and location of the aneurysm, or close to the dorsum sele, or more posterior, more higher position. But this is very important. When you remove the anterior clinoid, when you remove the posterior clinoid, you gain a lot of space anteriorly, and then you can enlarge the approach. This was in 92. This is the aneurysm. This is in the acute stage. So the living part of the aneurysm is smaller than the whole clot and the size of the aneurysm. As I said, you go along we are on the right side. you go along the silver fissure. You try to preserve the veins. You visualize the carotid artery. Sometimes you can cut the posterior communicating, and it might be enough to get to the basilar tip. And you don't need to resect the posterior clinoid, but usually it is necessary. So in this case, we went over the posterior clinoid. We dissect the pituitary body away from the posterior clinoid, and then we remove the posterior clinoid. So we get more space. We are at the basilar artery. We see the aneurysm. We see the posterior P1, but we need more space. The aneurysm here and P1. This is the P1 on the other side, P1 on this side, and we can put a clip. Of course, we have to be aware of the position of the perforators. And since this is in acute stage, we have to remove the blood clot. The whole aneurysm ruptured, was burst. So then we cut the aneurysm and we remove the clot. The remnants of the sac. The clot. Perforators. Perforator. The aneurysm is clipped. The perforators are preserved. P1 and the third nerve. P1. We control the positioning of the clip. P1 on the other side. And that's it. Now, it looks easy, but we have to be aware of complications. Complications number one are with the ICA, which is horizontal and parallel with the intradural carotid. So what happened to me, I was putting too much Surgicel into the cavernous sinus. This is the clip on the basilar artery, tip aneurysm. But putting too much Surgicel, I was occluding the carotid, as you can see here, and we have to reoperate and to take out the Surgicel, make it lax, and then the carotid was patent again. Complications too. We have to keep in mind that we are dealing with the normal cavernous sinus, that the venous bleeding may occur, and we may or we have to close the cavernous sinus. So we have to be aware of the normally functioning cavernous sinus and that the bleeding will be interrupting or disturbing us. Now it is easy. We just put the tisocol and then we block it, as Ali Krisht has shown the other day. Again, in the laboratory, we can train ourselves how to remove the posterior glanoid, how to visualize the pituitary body, how to visualize and cut the dural ring, how to visualize the intracavernous part of the carotid. Then we remove the anterior glanoid, we cut the dura behind the dorsum sella, we lift this wall and we can put the temporary clips on the basilar artery. We can go around the aneurysm and we put the clip and we remove the temporary clip. Complications 3. CSF leak may occur. Cranial nerves 2, 3, and 4 may be damaged. Posterior communicating and basilar tip perforators may go into spasm or we may damage them. To get rid of the anterior glanoid and posterior glanoid safely, get space around the ICA and dissect the ICA and optic nerve. Get space around the distal basilar artery and its bifurcation. Visualize P1, superior cerebral artery, cranial nerve 3. Aneurysm and perforators get ample working of space. Surgery of the basilar artery, the basilar tip artery, is one-way road. Mind your own physiology. Work slowly enough. Intermittent drilling, cooling, revising, hence retraction of the brain and vessels off. The perforators do not tolerate any clipping. To improve oneself a bit necessitates a lot of work in the lab. Surgery of the basilar tip artery aneurysm is not an art. It is the most difficult task, which does require one's optimal psychophysical capability. Neurosurgeon is not a superman or superwoman. Neurosurgeons should not be superstitious and or believers. They should be psychophysically prepared. Large and giant aneurysm intradurally. If you remove the anterior glanoid anteriorly, you get better space and you can preserve the carotid and remove the aneurysm. You see the case where there is no ACA1, or in such an aneurysm, partially thrombosed ICA aneurysm, and stenotic intradural ICA. We removed the aneurysm, the clot, and we reconstructed the carotid. However, it was not patent in the after surgery. Why? Because we did not calculate the depth of the wall of the aneurysm, of the artery. But the circulation was better. And here is similar, before and after. And the last case, huge aneurysm causing the epilepsy. DCA was not very convincing, very informative. That's why we performed other imaging, and we realized that there is no ACA on the other side. So we had to resect the aneurysm. First, to get space, we removed the anterior clinary process. We were able to go under the frontal lobe and then to resect the aneurysm, remove the clot, and to reconstruct the ACOM and to have a good feeling from one side. On this side, there is no ACA1. In our book, 1989, there were not complete information. So we had to rewrite and republish it and to make it complete. It took us 14 years. 2 years later, it was translated and published also in China. When this book came out, Dwight Parkinson wrote me a letter, and he said that this is the magnificent book, encyclopedic masterpiece, and how delightful to see the term cavernous sinus omitted. But you know, the pathologists and anatomists, they are die hard to change what they wrote before. And in 2006, we organized the second cavernous sinus meeting in Ljubljana, and to try to assess the progress and importance of the cavernous sinus surgery during the 2 decades. We invited also endovascular people, also the radiosurgery people, and we had a very, very interesting and fruitful discussions. I also presented how we develop in our techniques from the cavernous sinus surgery, which was published in '89, when we were using intradural approach to the cavernous sinus. What was wrong? Later on, we realized that this is extra cavernous, and we just have to peel off the dura from the lateral wall, and then we get nice approach to each part of the cavernous sinus, and we can go also transdurally, ossally, and so on. What has been learned in 20 years? The success rate is higher when the different modalities are correctly applied. Cooperation is superior to competition. From this meeting, the book was also published, which was also translated into Chinese, how the future developments and perspectives should be. Suggestion: joint forces, bigger centers, large volume of patients, and individual planning. In the future, the minimum end results will have to be equal to the preoperative status. No neurosurgical sequelae will be accepted. Most of present microneurosurgical procedures will remain, and many additional will be included. The problem remains. Surgery remains continuously and increasingly under fire. The history of surgery details a never-ending story of change and improvement. Surgeons must accept that no single treatment is best for long. One may find satisfaction and pride only as an active participant in the process. I am so happy that we have a very, very good neurosurgeons around the world, like Ernest Niemi, like Ali Krish, like Oliveira, who are good in surgery and who are able to put arguments against radiosurgery, against endovascular, against endoscopy. I had the privilege to work with Professor Steiner and with other experts in radiosurgery, and I never had problems. Spetzler told me that when they joined radiosurgery, endovascular, endoscopic surgery, he has more to operate because they are planning individually and they are assessing the best possible approach. But we have to be aware that nothing is complete, nothing is definite, everything is changing, and neurosurgery is not an exception. Thank you very much. I hope I did not take too much time.
Okay, Warlix.
Dr. Winko Dolenc for a really amazing lecture. So I would like to pass this on Professor Juha. If you want to say some things for like thanks to Professor Dolenc.
Thank you very much, Winko. It was a wonderful lecture. Showed extremely high skills, and many of those surgeries cannot be repeated anymore. So it was very good to see, and magnificent cases and difficult cases and well done cases. So I think you were concentrating on aneurysm now. We might ask you to give next week or in future second lecture on cavernous sinus tumors. So I think many people are waiting for that.
Let's put it in sometimes in January.
Okay, we will do that. And Professor Sana want to comment?
Hello, Vinko, my friend. Hello, Vinko.
Yes.
Hi. Yeah.
Oh, my brother.
Yeah, my friend, my brother. Now I'm remembering of the we did in cavernous sinus and first meeting in Ljubljana. Yeah, but I cannot say anything. But I'm still doing the surgery and sometimes saying about you and many friends. But yeah, we are very great. Yes, I am always remembering you. Okay.
Thank you very much. Thank you very much. Yeah. I have the best memories of being with you in Japan, yes, and so many other meetings and having you in my, yes, place and so on.
Yeah, exactly.
But I think what is important, and I'm really happy that we have people who are in good command of surgery. That means who are in good command of the anatomy, who are familiar with it. Otherwise, yeah, and there are different procedures which requires different skills and which requires a lot of experience, because no doubt everything is experience dependent.
More page. One more page.
Exactly. Yes.
Okay, Warlix.
Attention for the questions
What?
or any comment. Okay, if anyone have a question to ask Professor Dolenc, it's now open floor for you guys.
Hello.
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 Go ahead, Victor.
Hello, Vinco. Hello, Vinco Dolenc.
Hello,
This is
hello.
Victor Hugo. How
So
are you?
Let's go to Mexico. Let's go to Mexico.
Yeah, I remember that we met 3 years ago in China, and
Yes.
we were talking about the venous system importance to surgery, and you gave me your you told your opinion about the preservation of venous system, especially in the lateral aspect of the brain.
Yeah.
What can you tell us about the preservation, the importance of preservation of venous system?
I didn't get the question. What?
Your opinion about the preservation of venous system in the lateral aspect of the brain in the surgical approach.
The veins
of the brain, the preservation of veins of the brain.
Yeah, we did not so many, but we did studies on the fresh cadaver specimens, and we were studying the veins draining from the brain into the cavernous sinus. And there are we also published with the anatomist from Geneva. There is a publication how these veins are entering, and when some of them they go into the cavernous sinus, but mostly they go into the edge of the cavernous sinus and directly to the superior petrosinus. So I always try to preserve the veins from the medial aspect of the temporal lobe, and then follow them. At the beginning, I didn't care about this. I was just cutting them. But then I realized that some people have more atrophy of the brain in the temporal lobe. So I said veins are very, very important. And lately, I always try to preserve the veins, to follow them into the cavernous sinus. And then we realized that most of them are actually passing along the drainage system directly to the superior petrosinus. But I think more studies are needed.
Thank you, Professor Dolenc.
Hi,
Thank you.
Professor Dolenc. Thank you for your fantastic presentation. And you showed some amazing cases that you especially you take a high flow graft in the to substitute the ICA. So what kind of vessel you used for this graft?
Radial artery.
Okay.
Of course. I was somehow not successful in the venous grafts. Peepgrass and Sun, they did a large number of bypasses, you know, from the carotid and the neck, and then up But I was not successful, I mean, so successful in this. So that I took the radial artery, of course, after visualizing that the arch between the ulnar and radial artery is sufficient, and then the hand does not suffer. And in radial artery transplant, I was much more successful and happy. It's also easier to handle, you know.
Yeah.
And the diameter is near.
And you also mentioned some reconstruction of the ICA after remove the joint aneurysm. So are you suturing the vessel wall directly?
I couldn't go into the details, but I have three types of reconstruction after injury or resection of the aneurysm. First is local reconstruction. That is when you resect the aneurysm at the neck, then you can put some stitches, or you can put the round shaped and then the cuff clip, you know. But I prefer to put some stitches and then to enforce this with cuff clip. This is local reconstruction. Then the reconstruction is direct also. When you have to cut a part of the artery and the proximal and distal stump are close. So by mobilizing the medial loop of the ICA in the cavernous sinus and the anterior loop, you can approximate the artery, and then you put a direct reconstruction. But when the lesion is larger, then you have to put high flow, short high flow graft. And for this I use the radial artery.
Great, thank you.
And it is
fantastic.
It is possible when you have the proximal control and the distal control, and then you can spend more time, you know, and you work through the Parkinson's triangle or paramedian triangle. It depends where the lesion is located.
Dr. Dolenc.
Also dreaming. Hello.
Yeah, go ahead.
Dr. Dolenc. I'm Marco Baracas from Guadalajara, Mexico.
Welcome.
I have a question for you. When do you decide the endovascular therapy on surgery in basilar tip aneurysm? For example, if you have a tip very high to the clinoid, or when you have very low to the clinoid, the aneurysm?
You know, the higher and lower position of the bifurcation is just a variety which tells you how much space you need, you know. Sometimes you have to go more ahead and you have to remove more of the dorsum sella together with the posterior clinoid process. And if it is lower, of course, it's a little bit more delicate because you are not working away from the aneurysm. You are working actually over the aneurysm, you know. And of course, these are three variations according to the height of the basilar bifurcation. And the most important is to visualize the perforators. When the perforators are coming from the basilar tip, or sometimes from P1 on the other side, P1 on the other side, on one or the other side, then you decide, will it be possible to put the material, to put the coils or whatever into the aneurysm and not to occlude the perforators? Because the perforators are unforgivable. And this is, and then, for instance, you have a different rupture of the aneurysm. Sometimes the aneurysm is like a cauliflower, and there is no sac anymore. There is only blood clot at the top, which holds further bleeding, and it does need reconstruction. Now, I cannot go into the topics of the endovascular possibilities, you know, to put the coil, to put the stent, to put whatever. But I'm afraid that when the clot is dissolved, then the bleeding may occur again.
Okay.
So we always have to discuss with endovascular people if they can do safely. And this is also good. I think when we discuss with the family, with the endovascular people, with the radiological people, neurologists, and as a neurosurgeon, and we have to agree for the modality of treatment. Then, if something goes wrong, we will not be enemies because we reach the consensus before treatment. I think this also from medical legal point is very, very important to deal with each patient individually.
Thank you very much, Dr.
So we are under the same attack, you know. We are on the same boat, you know. The people are different and sometimes unpredictable.
Thank you.
The families, I mean. You're welcome.
Very good. Danu has a question, I believe. Go ahead, Danu.
Yes, thank you. It was a revelation, Professor Dolenc. I extremely captivated with your surgeries. I read your book published in '89. You mentioned that in order to get to the cavernous sinus, the CSF is contraindicated to drain. In the book, you mentioned that. However, in my experience, some little experience, we have ruptured aneurysm, which caused the brain to swollen, to swell, to edema. Can you enlighten me how to deal with the swollen edema to go to the cavernous sinus? Because the brain is not slack brain. You don't have slack brain. So would you please enlighten me? The second one is, how do you drill the posterior clinoid process in order to get into the posterior clinoid process? How do you drill the posterior clinoid process? Intradurally or extradurally, or do you have to cut the dura first and then you open the dura and then you drill the bone to get into the bigger room to go to the basilar tip aneurysm to clip? Thank you, Professor.
Yeah, very good. Very good question. How to get to the posterior clinoid? You remove anterior clinoid extradurally. Then you open the dura along the Sylvian fissure, and you go with the cutting of the dura toward the dural ring. And then you cut the ring, dural ring circumferentially. And then you are already at the posterior clinoid. Then you enter the intradurally, actually, in front of the posterior clinoid, into the sella. you push the pituitary body anteriorly. At the beginning, at the early stage, I put the Surgicel, but now you can put the fibrin glue, and then you have no bleeding. And you drill the posterior clinoid from the sellar side against the dura retrocellarly, you know. And of course, the trick, which I think is the most important, is you teach yourself before you start drilling. Oh boy, I will make only few revolutions, only 2-3 revolutions of the drill, and then I will stop. I will have the water cooling, and I will revise. If you start drilling when you are too far, it is too late. You cannot stop. So to train this, it is very good to talk with yourself before you start drilling from the sellar side, the posterior clinoid toward the dura. I will make only a few revolutions and then I will stop. You will never injure neither the artery, nor the nerves. But the greatest mistake is that one says, oh, we have to drill, and they start drilling, and they jump. And you need to include your own physiology, because when you see and when you proceed the whole thing through your brain, it is too late. So you have to plan in advance. Few revolutions of the drill, diamond drill, forget the cutting drill. Doesn't matter how big the posterior clinoid is. Few revolutions, stop, irrigate, revise, drill. Stop, revise, drill. Then you will never have the mistakes.
Thank you. But the first question,
that's a technique I use. The first question was?
The first question was, in the book you mentioned about the cerebrospinal fluid drain is contraindicated when approaching the cavernous sinus in the 89 published book, your book. I wonder how do you have a slack brain in order to get to the cavernous sinus?
You put the salt into my wound, which hurts me a lot. And you know why? Because no, it's okay. It's okay. That's why I put the evolution of the approach. The beginning and the description of the cavernous sinus surgery in the book of 89 is not good. People were coming to me from 89 on, and they said to me, but you are working now differently as you described in the book. Yes, because I was not aware, and I was using intradural approach. And this is bad, because if you go intradurally too early, you push the brain, and then the brain will degenerate. I had a lot of atrophy of the temporal lobe after surgery. After changing and approaching to the cavernous sinus extradurally, pulling the dura away from the lateral wall of the cavernous sinus, I do not have atrophy of the temporal lobe anymore. I'm sorry I published this, but I also corrected this. I published in the 2003 the epidural, and I also published in the last book, Future Perspectives, how the approach developed, you know. And this is intradural approach to the cavernous sinus is wrong. I'm sorry, I published it, but it is wrong. Extradural is correct.
Thank you very much.
You're welcome.
It's an honor.
Thanks.
Hello, Professor.
Hello.
Yes, I'm Dr. Harshit Parekh from Mumbai, India.
Welcome.
Yes.
It was excellent presentation, sir. We have heard you many times, and today was fantastic work you have shown of your past experiences and your expertise. I was privileged to watch you operating in when you came to India, Bombay, and you operated at Hinduja Hospital, 3 or 4 cases, and I have learned how to drill the ACP at that time, and a brilliant demonstration of ACP drilling at that time. And I agree, sir. We feel that all the cavernous sinus lesions should be approached extradurally, and even drilling we should do extradurally. I want to learn from you, how do you reconstruct the artery when it is cut and there is a piece there? What material you use? When you use a radial artery, what suture you use? What kind of sutures?
What
And high flow
I
bypass.
know. On bypass, I use radial artery.
Right, sir.
Yeah. Yeah.
And when you put a temporary clip, how long it takes to finish the bypass?
It is again very important question.
Yes, sir.
I did not mention in my lecture that we have to learn about the circulation of the circle of Willis before surgery. We have to know the condition of the both posterior communicating arteries and the patency of the anterior communicating artery. So when we have a discommunication, you know, we can do also some tests before we press on the carotid on one side, we inject on the other side, and we see how the blood goes over, how much and how fast. So you get information if it is possible to put the temporary clips on one carotid on the side of the pathology, and for how long. This we studied the venous return, you know. You inject on one side and then you study for how long the venous return does need on the other side. So this is also good test. Of course, it is much more difficult when you have no ACA1 from one side. When this your side where you operate is the only carotid and has no connections through the communicating posterior or ACA1 from the other side, then you are limited. Then I was fortunate. I didn't have such a case. In the cavernous sinus. But I had the cases intradurally, and I was able to manage it, you know, for very, very short time. But you are very right. If you need more time to reconstruct the carotid in the cavernous sinus, and there is no communication to the other side, no cross flow, then you are, of course, you're limited. Then you have to plan the bypass surgery and so on before.
Right, sir. Thank you. Thank you very much, Professor. Excellent presentations.
You're
We are
welcome.
waiting for your tumors to be seen. Cavernous sinus tumors, looking forward. In January, you said you will
Thank you very much.
present. Thank you. Good to see you, sir.
Yes,
Thank you.
yes.
Thank you.
Thank
we
you.
have
Thank you.
another question.
Best regards to Dr. Juha.
Yes, thank you. He's moved to Delhi, New Delhi, but I meet him. I will definitely say.
I know. He's in the institute.
Yeah, yes. He was there when you came to do 3-4 surgeries. An excellent presentation there. Yes, we were there.
Okay,
sir.
thank you.
Thank you.
Thank you. You're welcome. Thank you.
Okay, there's a question from Dr. Kilis, Abdullah Kilis. You want to ask questions? You there?
Hi, Dr. Dolenc. Thank you so much for your great lecture. It's an honor to be joining your lecture. I have one question about the basilar sacrifice the PCAM. Did you have any complication to sacrifice PCAM?
Sorry, I didn't catch you.
Can you repeat that, please?
Yeah, sure. So how do
Can
you
you repeat the question?
Sure. How do you often sacrifice the PCAM for the basilar tip aneurysm surgeries?
Can you repeat the question to him, Warlix?
I don't.
Yeah, I think I can explain.
His question is
because sometimes in the Ali Krish's presentation, sometimes when he want to get more position for treat the basilar tip aneurysm, he will sacrifice the PCAM PCAM artery.
The PCAM, yes.
Yeah. In the segment without any perforators. So I think he want to ask the question about sacrifice the PCAM. Is there any problems?
No, I did not have a problem, but I was very careful all the time of the existence of perforators from PCAM and the location of these perforators. Sometimes they are closer to the carotid, sometimes they are closer to P1. So you have to decide where you interrupt the PCAM. But I do not interrupt it, I do not cut it when I don't need it. So otherwise you have to calculate that the filling of the perforators through the PCAM, distal or proximal, will be sufficient after dividing it, And I put on the, as you saw, I put on the PCAM the liga clips, ligating clips, and then I cut it. But you have to orient yourself according to the origin and location of the perforators from PCAM. So if they are if they are very, very close together, you may cut the PCAM very close to the P1 so that you preserve the perforators, or the opposite.
Okay, thank you.
Professor Winkle, so tonight we also broadcast in the WeChat channel. So until now, there's more than 3,200 audience watched your presentation.
Right.
Thank you very much. Thank you. And thank you for your help.
Congratulations. Yeah.
Thank you. Thank you. It's my pleasure.
Okay, Warlix.
Professor Juha, you should unmute yourself.
Unmute.
Juha is speaking, yeah.
Yeah, okay. Unmute, Juha.
Okay, dear Victor,
You went to sleep.
we wish you happy Christmas, but also we are waiting for you in January here with cavernous sinus tumors. So you will have even more audience that time.
Okay.
Okay. So have a good Christmas and New Year, and see you in January. And thanks to all.
Yeah, we'd especially like to thank the translators.
Thank you,
the translators, Ben and Dr. Liao. And we welcome the Chinese neurosurgery community and thank Juha for bringing the best of our civilization to China as far as neurosurgery. Okay.
Professor Sano is here, so he will present 25th, I think so. No, 15th. No, 25th.
Okay. Okay, we'll keep everyone in mind. Go
25th
ahead.
would be okay, yeah? Yeah.
Okay, go ahead, Warlix. So you want to close it, Warlix? Well, I guess Warlix is taking a nap. Okay, we'll see everyone in a couple of weeks. Thank you very much, everybody.
Bye-bye, everybody. Good night. Good day.
Thank
good
you.
morning.
Okay, very good. Okay, we stopped recording.
Thank
I
you.
was scared, Vinko, that you weren't gonna.
We could like remind our audience that also the December 22 is going to be Dr. Sano.
Okay, yeah, this is our chance, Warlix. We got to show what's going on coming up. Let me screen share something, if it's okay with you, because you're the boss here. Is it okay if I screen share something?
Yeah, sure.
I'm just joking, Warlix. Jeez.
I know.
We're off the air.
Tries to screen share.
Oh, okay. You're starting something. Okay, yeah. I was going to show you that the one from Sunday on virtual reality. Is that the one you're showing?
No, it will be because we still on Juha one. So
Okay.
okay. Let's share it.
We have a captive audience of 35.
Okay.
Mauro, you still there?
So it's gonna be our next like Juha sessions will be Dr. Sano.
Oh, great. You've already, that's right. You did the banner already. So that's the 20, okay, 22nd. Very good.
Yes.
Yeah, we like the gym pictures. You can. No. No, okay. Let me screen share what's the next webcast for us. So a virtual reality webinar from London. Okay.
Oh, and Dr. Victor's too. Dr. Victor, he will have to present on the neuroanatomies on this Monday.
Oh, Victor. Yeah, we forgot to mention that. Victor was here. Victor, you're still here?
Yes, December 14th, we will lecture about Libellum's fourth ventricle approach to fourth ventricle.
Yeah, we should have mentioned that when Victor was here. He could have asked. Okay, anyway, Sunday, this young lady's a medical student, 5th year from London, but she's working with.
Hello, dear friends.
Hey, is that Victor?
Yes.
Okay, Victor. Okay, let me get off this. I'll let you. Okay, I'll let you talk about the conference you're going to have on Monday.
Yes, on Monday.
Yeah,
What's
yeah.
the name?
Yeah, she meant the wait. Yeah, she meant the banner. Let me get the banner. Go ahead, Warlix. Can you share the banner?
No, I can't because.
Okay, let me share it. Let me share it then. You just sent it to me, right? Let me just download it real quick.
Yeah, I have my gym.
You sent it to me by Facebook, right? So
3 weeks in a row for interesting neuroanatomy from Dr. Victor.
Yeah, and Victor can answer any. This is
Look
advertising
at
at
my
its
dog.
best.
Look at my dog.
Oh, that's cute. What's his name?
It's
Warlicks.
No, that's not
the
my.
name brunette, brunette.
That's cute. He's a big one. Oh, not.
Hi, Victor.
Hi, how are you?
Okay,
I'm
Victor.
fine.
Victor's gonna tell us about his lecture on Monday.
Yes, next Monday.
Cerebellum and fourth ventricle approaches to the fourth ventricle.
Yes.
And everyone here is invited. We haven't made the link yet, but it'll be on Neurosurgical TV or the Facebook page, or you'll get an email about it. We'll certainly advertise it because we're proud of hosting Victor. We posted him in English and Spanish, and he doesn't know Thai, but
It's okay.
Yeah.
Thank
Thank you.
Cute dog.
Yeah. Hello.
Hi,
Internet.
Victor.
Hello, how are you?
I'm fine, Victor. How are you? Nice to see you with the dog, Pat. Your pet is beautiful.
Oh, thank you so much. Nice
You
to
are
see you
looking.
too.
Yes.
It's not hard at all. It's so nice. He do not.
Yeah,
bark,
so nice. Yeah.
do not bark. So
I feel you are on a holiday.
Yeah, I'm going to do some exercise with with bikes and my
Okay.
dog
Wonderful,
and my
wonderful,
wife.
wonderful.
you're going to the country. You're going to the country.
Enjoy, enjoy.
Yes.
Hey, Victor, mucho mexicanos aquí. 5 or 6.
Yes, of course. I put some kamikazes.
Okay. Oh, that's why. Oh, yeah. You could tell. I was wondering where all these Mexicans come from. I think we had at least 4 or 5 neurosurgeons from Mexico.
Yes, of course.
Great, great, great. Victor, enjoy yourself.
Okay. Hello, Abu Bakr. Abu Bakr's here from, let's see, Abu Bakr. Are you there, Abu Bakr? No? Okay. Anybody else that wants to introduce themselves and just say hi? You know, this is actually the time. Hey, Marco Antonio, you there from Bolivia? Is that the same Marco Antonio? Nope, he left. He must be Marco.
here. Marco's still here.
So Warlex,
yes,
go ahead.
Yes, I'm from Guadalajara, Mexico. You remember?
Ah, sí, yo estoy en Teco. Yo fui a la escuela, Universidad Autónoma de Guadalajara.
Yes, of course.
Yeah. How you doing?
Good, and you?
Yeah, good. I'm glad you're here.
Yes.
That's a beautiful
Hello,
background. Look at that background, Victor. And
Hello,
Warlex.
Marco Antonio Barajas. Nice to see you in TV Neurosurgical with the great John Bennett.
Yes.
There we go. I used to live in Providencia.
Yes.
Yeah.
I'm here in Hospital San Javier in Providencia, near of the Autónoma de Guadalajara. You remember?
Yeah. And Zapopan is growing, huh? Zapopan.
Yes.
The hospital is getting bigger.
Yes.
Oh, that's good. Well, bienvenidos.
See you later.
Okay, tú estás en la lista para recibir noticias, ¿verdad?
Yes.
Okay, perfecto. Okay. Anybody else that want to say hi and introduce themselves? Because this will become a networking time.
I got private messages. So next Juha neurosurgery from Dr. Sano the topic will be advantage of the clipping surgeries of aneurysms. by Dr. Hirotoshi Sano. Okay.
Oh,
For the-
okay, that's
for-
good. What else we got going on, Morlix? Let's see. Oh yeah, we have the. Okay, yeah. Let me show the conference from Monday, from Mexico City, Victor, and everyone. Yeah, a lot of good speakers here. And Morlix, you can go ooh ah if you want. If you. Okay, there we go. You see that, Victor? And the Los Mexicanos.
Sí.
Sí,
Sí,
está,
John.
sí, esta está de México, este congreso. Yo
Sí.
creo que sí. Entonces, Michael Lawton speaking Monday morning, I believe at 10 o'clock Mexico time, which is 11 o'clock Eastern time. Okay, and Babek Kateb is a neuroscientist from LA, and Juha is speaking on Tuesday, and Salim Abdulraf from St. Louis, Walter Dandy Association speaking Tuesday afternoon. Marcus Rota, I think you know him, Victor. He's from Brazil, I believe, a neurosurgeon from Brazil. And everyone knows Atul. He's speaking Wednesday afternoon. And of course, Ipe, the mentor of this website, or this project actually, is Thursday morning. Louis Borba, everyone knows his name. Thursday afternoon. Claudio Yampolsky from Argentina. Friday, Oscar Alves from Portugal. He's a big C-spine guy. Mustafa Vazkaya. We've done a few webcasts with him. He's a neurosurgeon. I don't know where he's from originally, Lebanon, I don't know, but he's practicing now in Wisconsin, University of Wisconsin. And Parmenides Guadarrama, I don't know. Victor, do you know him, Victor? Parmenides Guadarrama Ortiz? ¿Conoce él los mexicanos? No?
Excuse me, which one?
Parmenides Guadarrama Ortiz.
Okay,
Parmenides.
yes, I know him. Yes, I know him.
Okay. Okay, he's speaking this week on Saturday. So this conference is divided up. One speaker in the morning, one at night or the afternoon. Kind of unusual, but that's the way it's structured. And Victor, that conference in Argentina on strokes, that was a great conference because there was a mixture of online, and they had a lot of speakers that were on site in Buenos Aires. So it's going to be the future, a mixture of virtual and a mixture of in-person. So I don't know, Victor, if you're excited. I'm excited. How about you, Warlocks? Are you looking forward to the hybrid development of in-conference and virtual? Hello, Warlocks, are you there? The speaker left.
No, John, yeah. No, of course, I share with you the happiness, dear Bennett. You are doing a great job with TV Neurosurgical, and I am also very happy to be here with you and with giants of neurosurgery like Binshu, Juha Hernesniemi, Vinko Dolenc.
You know, Juha is behind this to bring to China the best neurosurgeons. He's trying to bring, which is great. He's trying to bring the best to China.
Yes, I know.
That is a great thing that he's doing.
Yes.
And I'm sure they appreciate it. I know that Ben appreciates it, and it's great to have him. So, okay.
Okay. I see you next Monday.
Okay, very good, Victor. We'll promote it and we'll see everyone else.
Thank you very much.
Okay, but